Education meeting. We've got a really nice agenda that I'll share with you after the first presentation. We're going a little different today, but we've got Dr. Findley and Dr. Baltz to do a presentation on MEMs for melanoma, and looking forward to it. So with that, I will turn it over to Drs. Findley and Baltz.
Awesome. Thank you, Rich. So thank you everybody for coming out tonight. We were really hoping to do this presentation in person, but nobody's doing anything in person anymore. So excited to share this with you guys over Zoom. Alyssa and I both work at Dermatology Professionals out of East Greenwich, Rhode Island, as well as out of North Attleboro, Massachusetts. And one of the things that we offer in the North Attleboro location is MEMs for melanoma, which Alyssa started this in our location. We're pretty much the only one in the region. So we wanted to talk to you guys about what we do, why we do it, and excited to share a little bit about us. So we have no disclosures. And our goals tonight really look first at how the guidelines for the treatment of melanoma in situ and invasive melanoma have evolved over time. Look at what exactly is MEMs for melanoma, and then talk about how best to select your patients to send for MEMs for melanoma. So I think most of us learned in residency that for melanoma in situ, you treat with 1/2 centimeter margins and you're good to go. I know that's what I was taught, sort of drummed into my head. So where did this come from? Well, in 1992, the NIH put together a panel to come up with a consensus statement on the treatment of in situ and early invasive melanoma. And what they found, what they agreed upon, was that for early in situ melanoma, 0.5 centimeter margins were appropriate. So this is where this comes from. But what's important to note is that this was based upon consensus. So we didn't have any studies to back this up. It was these people in a room looking at what they did have and saying, I think this is sufficient. So during and around this time, people started looking into, well, in practice, is it actually sufficient? In 1997, Vitelli's group put out an article in the JAD where they looked at en face sections of melanoma in situ, stained with H&E, to see were those 5 millimeters enough. And this was one of the first papers where they published findings that they continue to publish on for the next 20 years, essentially saying you need 1 centimeter at least to treat a melanoma in situ. 5 millimeters is just not sufficient, and this shouldn't be a recommendation we're leaning into. In the UK, a survey went out to say, okay, well, what are our dermatologists doing? And similarly, they found there really was no consensus because there was no data. And furthermore, a study that came out in the JAD, again, looking at en face sections of melanoma, found that 5 millimeters was sufficient in the treatment of less than 50% of in situ melanomas. So again, while we have these NIH consensus recommendations in our heads and in our training, there's all this emerging data which is asking us to take a closer look and maybe question what we're doing. So what were we actually doing? In 2005, a study came out in the archives that was a survey-based study to a number of US dermatologists. They received about 600 responses, which is pretty good. 63% response rate is pretty good for a survey-based study, asking how US dermatologists were actually treating their melanomas in situ. And what they found, not surprising, there's no consensus. Some people are treating with greater than 5 millimeter margins, some people are not, and some people aren't really willing to disclose. So to try to elucidate or sort of give us better guidelines than those given by the NIH in 1992, this group in 2011, through the JAD and the Academy, put out a consensus statement to try to guide our treatment of melanoma. Now, looking at this group of people, these are all people we recognize. These are respected members of our field. So these are recommendations, we feel we could lean into. So they graded the recommendations based upon an A for really good evidence versus a C, which is our consensus, our opinion, our case studies, and gave us recommendations for the treatment of melanoma in situ. What they found, between 1/2 and 1 centimeter may be enough. And if you have a lentigo maligna, maybe we should do more. But again, this was based upon consensus, not based on data. And really it doesn't help to guide us, because they're still saying, well, maybe 5 millimeters is enough. So with this idea of really not knowing what margins to take, most surgeons started to think about, well, we have this tool for the treatment of non-melanoma skin cancer, which is the evaluation of our margins directly so that we can confirm clearance and take exactly what needs to be taken. So Zitelli, who you're gonna hear me say his name a million times, who's really pioneered this, started looking in the early 90s and even the 80s at Mohs for melanoma using MART1 immunostains. And again, in this paper that came out in 91, similarly, when he looked at Mohs for melanoma stained MART1 frozens versus permanent sections, he found that there was no difference in how these were read. So he's starting to plant the seed that these are reliable slides to read through a frozen section in clinic versus having to send for H&E, with sort of contrasting the common teaching that melanomas are hard enough to read on H&E, therefore frozen section read is just impossible. Carucci, who works out of NYU, further wrote a really good clinics piece to say, dermatologists, most surgeons can identify melanoma on frozen sections, and this should be something that we have in our toolbox for the standard of care of melanoma in situ. And this is back in 2002, again, when we're still getting those recommendations for 0.5 centimeter margins. Furthermore, multiple studies were coming out past then, again, showing that most surgeons know how to read MART1 immunostains. Even with the short 19-minute protocol as seen in this paper, the stain is good enough, clear enough that with appropriate training, this is a legitimate modality to evaluate melanoma. So where I think this point was driven home and why this started to change standard of care came with the 2012 paper, again out of Zitelli's group, where they looked at over 1,100 melanomas, and they took en face sections starting with 6 millimeters, examined them, and then essentially measured how big the margins ended up being with complete excision of these tumors with en face sections. And what they found was 6 millimeters, which is greater than our recommended 5, only cleared 86% of our tumors. Now, I don't think that's acceptable for any of us, for our patients. And what they found was 9 millimeters was where we are actually treating our patients well, so almost 99%. And this is where, this is like, this study with good data, big numbers, started to drive home this point that we need to forget about 5 millimeter margins, and we need to start thinking about these as more insidious subclinical tumors where direct margin control can lead to a better and appropriate cure. Well, you can't just make that out of conjecture. So a group out of Mayo Clinic, they also looked at upstaging. So one of the things we consent our patients on when we look at a melanoma in situ is that although the first biopsy may say that it's in situ, there could be an invasive component. What they found in this paper, looking at over 600 melanomas in situ, was that interestingly, in a number of these, the invasive component was 5 to 10 millimeters away. So this is pretty scary when we're thinking about 5 millimeter margins of an in situ melanoma, and we might miss the actually dangerous part of this tumor. Now, what about lentigo maligna? I think we were all trained that, and it even said in the 2011 consensus statement through the Academy that, well, if we're thinking lentigo maligna, maybe we should take greater than 5 millimeters. So is there really a difference? Well, again, Zitelli wanted to investigate that as well. And what they found is there really is no difference. You need 9 millimeters, regardless of the subtype of an in situ tumor, if you're really going to clear it. Now, with all this emerging evidence on physicians being able to read en face sections with frozen, with MART1 immunostains, then the next question is, okay, so Zitelli's reporting this stuff, but can it actually be done? Does it affect survival? How does it compare to wide local excision? So over the last 3 years, definitely in the last 2, multiple papers have come out investigating this point. In JAMA-DERM in 2019, they found really no difference in wide local excision versus Mohs for melanoma. So this is a inferiority study, and we're already seeing, okay, it's a non-inferior way to treat these patients. And further study from Zitelli's group, again, showing 5mm margins are not enough. And he combined this with a multi-center group, therefore showing it's not just him, it's colleagues around the world who are doing this. And since that time, we've just seen this explosion of papers investigating survival and finding that essentially there's no difference in survival. There's no difference in recurrence rate. And even they're starting to see that with melanoma in situ, as well as early invasive melanoma, you might actually get survival benefit. So all of these things come together to illustrate the point that we need to throw out 0.5 centimeter margins for melanoma in situ, whether we're treating it on the face, whether we're treating it on the back, doesn't seem to matter. It's data has built up to show that it's not quite adequate. And furthermore, if we're thinking about melanoma in situ and lentigo maligna, which is showing up in the face in sensitive tissue areas where 1 centimeter is a big deal, the idea of on-phos margins and direct tumor visualization becomes more and more relevant in our treatment of our patients. So at this point, I'm going to hand it over to Alyssa to talk a little bit more about what we do and how we do it.
All right. Am I forwarding these slides, or are you still doing it, Julia?
I think I'm doing it. So
all right, so I'll just kind of give you the signal. So thanks for having us speak. This is something that, like Julia, mentioned, I became very passionate about soon after I completed my fellowship training. It is, as she mentioned, a service that currently is only, to our knowledge, offered in Boston. So patients really have to travel pretty far to get this procedure done. I had my little guy on the corner draft what he thinks mom looks like at work, and that was his interpretation. Melanoma days are definitely some of my more stressful days, but they are super, super rewarding. And, it was really fun training Julia, and now having us both do it is just a really great experience. So we can go forward there. So this really started for me with my residency training. I was at Geisinger for my residency, which many of you may know is pretty much Amish country. Howard Pride, the gentleman with kind of the green shirt in the middle there, was my mentor. Really, he encouraged me to go into dermatology, and is just an amazing clinician. I had the opportunity with two of my close residents, Highland Cronin and Amy Delaney, who are the girls there pictured. They were a year ahead of me, but they were super interested in surgery. We used to kind of sneak over during lunch, and we would find out what was going on in the Mohs surgical suite. We had the luxury of being at an amazing academic institution where Vic Marks, who's pictured down below, who was the chief of surgery at the time, we would oftentimes kind of listen in and get in on some of the Mohs for melanoma cases. It was even more luxury because Dirk Elston was the chair of dermatopathology at the time, who's also pictured there. So literally we would be sitting down with surgeons and dermatopathologists and looking at these MART stains. And it was just priceless. So I knew at that time it was a big interest of mine, and it kind of grew from there. So we can go forward. So my main goal for my part of this presentation is, why do we do Mohs for melanoma? Why is this such an important service to our patients? And, how this really sets us apart from many dermatology groups that don't offer this. So, first and foremost, as dermatologists, we are the experts at melanoma treatment. We know this disease, this tumor, and so we are really the people that should be taking care of many melanomas. we are the only surgeons that can, as Dr. Baltz was talking about, provide that complete margin examination at the time of tumor extirpation. So that in and of itself is just the kind of quintessential reason of why we should be doing this, and more people should be doing it. And it truly is the best and preferable treatment option for most patients. Patients, for the most part, love it. Many of them are familiar with what we typically kind of allude to as slow-mos, which is a staged procedure. Occurs oftentimes over a week or several days. It's not convenient. And so being able to offer a procedure that's done in a one-day setting from start to close is just really, really beneficial. So we can go forward there. So this slide is really just to say that, you know, most of us as clinicians, we know what to do when we see a really bad spot. We know to biopsy it. We know it's probably not good. The image of Macaulay Culkin, we generally have that going off in our head. You know, we're thinking this is not good. We try to keep a straight face. So, you know, I think we know what to look for, and we know what to do in that sense. But there's really a big gray area in terms of how we manage a lot of these melanomas. And as Dr. Baltz kind of gave a good background on how these are managed, that's why we'd like to talk about the importance of Mohs for melanoma here. So we can go forward there. So when I first kind of was thinking about doing this, you know, it was quite an overwhelming and daunting task I felt like I had in front of me. Even though I'd had the Geisinger exposure, I felt like the slides would potentially be very difficult to read. How would I get that reliable staining? I wasn't sure that I could do that without an automatic stainer and without lots of people in the lab assisting me. I thought it would be very time consuming to develop a good protocol and how this would play out. I wasn't sure about the feasibility of doing it in a private practice. You know, when you're at an academic center, as I was exposed to, I was surrounded by really anybody I wanted to talk to. So if I wanted to talk to the surgical oncologist or the medical oncologist or just the derm path, they were kind of right there. And I felt a little bit alone, and that made me nervous. And then there was a study out several years ago, but, you know, most surgeons aren't still doing this procedure. So it's not commonly done. And again, that's, I think I just wanted to take on the challenge. So we can keep going forward there. My breakthrough was that I realized I had to have faith in the fact that I had more training, well, more exposure, I would say, than many Mohs surgeons. I felt up for the challenge. And again, as I mentioned, I felt like it was really a much needed service in our area. I also did some investigation. I remember I called Vic Marks, again, who was my surgical mentor at Geisinger, and I said, I think I'm going to do this. And he, you know, his response was, well, just make sure that the immunostains are covered so that you're going to get reimbursed for this and it makes sense. And sure enough, in Rhode Island and Massachusetts, that's not an issue. So we can keep going forward here. I basically started with just printing out every single, I'm very old school when it comes to that stuff, so I printed out every single Mohs for melanoma article I could get my hands on. I did a huge lit search. I spoke with several people in different states that were doing this, in Vermont and Pennsylvania, California. I took a look at every single person's protocol, and my amazing techs and I just basically started practicing, and we would take standing cones from some of our excisions and we would start doing staining. And the staining we have now is definitely vastly different than what we had on our first couple. But it's been, you know, super, super rewarding to develop that protocol with the staff I still have there now. I also got really good advice, and that was, you know, find some dermatophathologists that you can kind of sit down and do a good internal review with regularly. So I found some people that I would sit down, they would look at my first, you know, series of cases that I did. They would comment on the staining, on the findings. Most often they agreed with me. Sometimes they had other comments, but it was just a really big learning experience. And it's still a work in progress, but we've come a really, really long way, and I'm very proud of what we have now. So moving forward, and just put this slide in there. It's quite a learning curve when you're doing something like this, but again, very rewarding. I think we just want to go forward to the next one. Yeah. So, I think the other motivating factor for this is that, there's a big practice gap in dermatology, and particularly dermatologic surgery, when you're thinking about how melanoma is treated. So Dr. Baltz alluded to this very well, but oftentimes melanomas are treated with wide local excision. I get a lot of referrals for patients where they say wide local excision, or they say slow-mos, or very infrequently does it actually say Mohs on there. So one of the things I certainly want to accomplish with this is so that hopefully those that are listening have a little bit of a better understanding of what they're sending a patient for. A practice gap is truly the difference between what's an actual and ideal, or what's actual and ideal in regards to patient outcomes and performance. And what's, current practice and best practice. So again, current practice is oftentimes patients get referred for wide local excision, when oftentimes many of these cases would be very appropriate for Mohs with margin control. A big part of this is that melanomas, particularly on sun-exposed areas, oftentimes head and neck, but also very, very frequently on the trunk and extremities. They really, particularly these lentigo malignas and other tumors, they have a lot of subclinical extension that I think really deserves a lot of respect and appreciation, and can be quite tricky. So having that margin control really leads to a better outcome in most patients. And so that just, again, my final point on this slide is just that these many early invasive melanomas and then melanoma in situs, you'll have a better cure rate and overall survival when treated with Mohs. We can keep, so that, I'm sorry, just to go back, that last slide, I thought, that was a recent patient of mine. I put her in here. It's a lovely, lovely lady. And I think that this picture really kind of says it all. If you're referred a patient with an ill-defined kind of all shades of gray, brown, white, pink as well, lesion that's occupying, the vast majority of her nasal ala, extending onto the supratip and the tip, and even a little bit medial cheek there. That is just completely daunting to think about doing that for me with anything other than Mohs, with that margin control, assuming that this is an appropriate tumor, which we'll get to in a couple of slides. So we can go forward. Just to follow up on this one patient, that was once she was clear after Mohs surgery. I ended up repairing her with a cartilage graft, an advancement flap, and a perimedian forehead flap. I actually just saw her today for her suture removal visit after her takedown procedure, which was kind of cool. And I told her that I'd be presenting her tonight. She's doing great. So I think, this is one of the big reasons we have these big, big cases. And I think we can fast forward. I show a couple more pictures, but when you have these patients with just very, very large tumors, just crazy kind of subclinical extension, that ability to have that margin control is just really, really key. So we can keep going here. So, what is the real argument or reason why we would do Mohs versus a slow modified Mohs, or what we call slow Mohs or en face staged excision? For me, there are several arguments for Mohs for a lot of the tumors that we get referred. I always questioned the accuracy of when we were doing slow Mohs, and that's what we did during my fellowship. And, certainly it's not a bad procedure, again, less convenient for a lot of patients, but, I didn't have a great, let's just go back for 1 second. I didn't have a great relationship not a great relationship. I just didn't know the pathologists that were reading my specimens very well. You can have some tissue changes during the processing. So formalin fixed tissue can shrink a bit. You can have some pull on the epidermal edges. So I always questioned if we were getting 100% margin evaluation. It is definitely not convenient for many patients. You know, you would get started on a Monday, you would remove your specimen, your margin, you would send it off for overnight processing. You know, I wouldn't sleep that night knowing that the patient was going to come back somewhat grumpy. If you have to take more, then it's a whole nother 24-hour process. So it can really, you can spend a week with these patients. And for a lot of older folks, it's just very difficult on them. You also have an open wound. That potentially is increased risk of infection, bleeding. I certainly had that happen to me. So you can make the argument for increased morbidity and then, of course, higher costs. So we can go forward there. So what actually is Mohs for melanoma, and how do Dr. Baltz and I practice this? So again, Mohs for melanoma is all about margin control. So it's about getting 100% visualization of that margin. And that is really the key of what we do. You're getting that frozen section evaluation of the margins by the Mohs surgeon using MART-1. There are some of my colleagues, particularly in Pennsylvania, that use an MITF immunostain. I've thought about dabbling with it at several points. I think I'm finally getting brave enough. I've heard that it's a little bit more finicky. So I just haven't, I haven't done it yet, but I'm thinking about it. One of the things that was really ingrained in me since my Geisinger time was that you always want to send a debulking specimen when you're doing this, meaning that you always want to take kind of a central specimen of where that original biopsy was. And you're sending that for confirmation of the depth of the tumor to make sure that there's no upstaging and no need for any other treatment following Mohs. So our kind of rules for this are that for a lentigo maligna on biopsy, we start with a 6 millimeter clinical margin and we go down to the subcutaneous fat with our debulking. For a lentigo maligna melanoma or a melanoma with an invasive component, I'm going to always start off with a 1 centimeter clinical margin to fat. So no, it's not always tissue sparing in the sense that you're taking less of a margin. You oftentimes are, but not always. But I think the key is, again, the margin control there. So this was a diagram. This is kind of like my, this piece of paper I should have framed, because this was like so key to me starting to approach these. And it looks just like a lot of writing, and it's not going to make a ton of sense. But this was from my mentor, Vic Marks. And this is where he was trying to show me, you know, as I was trying to gain confidence in reading these and our protocol and what we were doing, the diagram basically shows that you're taking a central debulking specimen always. You're taking your peripheral specimen that you're going to be using the MART-1 on. And then a lot of times, if there's clearly frank tumor still present, I will take additionally a small kind of rectangular specimen emanating from the center, from the debulk, and extending to my peripheral margin. And I'll also test that in the lab. That gives you the ability to see your tumor. But as well, it also gives you that ability to kind of see that transition from tumor to just sun damage or what that patient's, you know, quote, normal skin is. So this is oftentimes the way I approach these. Indications for Mohs and you know, who should be sent for these. For appropriate use, it's generally head and neck based on the size and the anatomic location. Poorly defined margins, almost all of these kind of meet that requirement. Trunk and extremities are deemed uncertain, but I can tell you in my experience, trunk and extremity lentigo malignas are oftentimes the more difficult cases. And so I now more frequently, if I can meet the size criteria, which oftentimes using a Woods light, I will oftentimes treat these with Mohs. I put our Findley Baltz criteria. So that's kind of like our approach to what we will treat. So generally a T1B or thinner melanoma. There are pretty few exceptions to this. You know, certainly you have to look for those other features that may warrant a patient being referred to surgical oncology for sentinel lymph nodes and that sort of thing. But for the most part, our Mohs protocol is T1B and thinner. A lot of times you'll get these path reports that have a quote early evolving melanoma or suggestive of an early evolving melanoma. And so those meet criteria for treatment with Mohs. And again, I think I'm just kind of being a bit redundant, but no matter what, we're always sending that debulking specimen. So we're always going to get that extra bit of information about if anything was hiding out other than what that original biopsy showed. So again, who should be sent? Just to reiterate, appropriate clinical selection, so body location and size. If there's ever a question by any of you about, who's appropriate or who you should be sending, please, send Dr. Baltz or myself a communication or give us a call, because there certainly can be a little bit of a gray zone with this. And again, with histology, sometimes path reports can be a bit vague. I oftentimes find myself calling the pathologist with a report and just for clarification. Sometimes if I'm the one doing the biopsy and it's a smaller biopsy of a larger lesion, a lot of times I'll have a conversation with them about my clinical concern, or I'll bring the patient back for a repeat biopsy. But you do really have to have that kind of evolving early melanoma, and of course, frank melanoma to meet their criteria for most. Optimal biopsy technique is, I think, an important topic. And, my training, and again, a lot of this comes from Dirk Elston when I was at Geisinger, but you can see the lesion in that picture. It's clearly very, very ill-defined. This was my marking pre-wood slamping the lesion. The center kind of whitish, what looks whitish in that picture is the actual biopsied area by the referring dermatologist. The problem with small biopsies is that they're oftentimes going to lead to a misdiagnosis, or they're just not going to be diagnostic. Skip areas are super, super common in lentigo malignas. So it is so frequent that you'll see tumor and then you'll see a pretty good area of just their sun damage, and then you're right back to lentigo maligna. You oftentimes, in a lesion such as this, we'll see other benign pigmented lesions. You can see pigmented AKs, you can see solar lenticos, and they're often colliding with the lentigo maligna. They can certainly be tricky on pathology, but again, a reason why a broad shave biopsy is best. So that was my training. Certainly you want to, the old saying that we had in residency is you want to really biopsy to get the rainbow. So you want to get kind of all colors you can. And it's often super beneficial for your pathologist if you can get a little bit of what looks like normal skin in that broad shave, so they can also kind of see what that patient's baseline is and see that transition. So moving forward. So here are just some recent patients of mine. This gentleman in particular, a young guy, I've taken care of him for some non-melanoma skin cancers before. This biopsy was originally read as a severely atypical lesion. When I looked at the clinical and I looked at the pathology, I called because I really just felt like the picture was that of a very ill-defined kind of pigmented lesion. We were able to amend that to an evolving MMIS, which I drew out kind of the margin I would have taken in the one picture if I were just excising this, and that's after Wood's lamp examination. So I think, the key to this photo is that it's really showing, how you can have better margin control and potentially also be tissue sparing, which obviously in this location being right in that superbrow area is going to have some good implications on closure. I did end up doing an advancement flap on this gentleman, but that's the margin you're taking in that actual wound, then it can end up being quite large and implications on the closure there. Again, this gentleman was interesting. He's had several melanomas with me. The picture on my left was his original. He actually came in to see me for a basal cell in a different location. What I had circled had been biopsied previously by one of our general dermatologists. A part of that kind of pink area was biopsied. It was actually read as a moderately atypical melanocytic proliferation. So when I saw him back for treatment of his basal cell, I said, I really think, why don't we just kind of do a broad shave of this area? Sure enough, it came back as definitive lentigo maligna, and so we ended up treating him with Mohs. And again, you know, this is kind of what I got kind of a little just crazy and quite honestly just got tired of having to try to draw these margins around tumors like this. I would try to draw my excision margins. This was after I had woods lighted this gentleman. And again, I just kept seeing these hypopigmented areas and hyperpigmented areas, and it kind of just gets very crazy. And so to be able to treat this tumor on the shoulder with Mohs, I'm sorry, was just so important here, I think. If record serves me right, I have written down that he went 4 stages. So a lot of what I had circled that was just a little bit hypopigmented ended up being clear melanoma in situ under the microscope. And again, this was actually one from this week. This was my drawing after I had woods lighted him. So you can clearly see the crusted area was the original biopsy showing definitive. He had a T1A melanoma. And then when I woods lighted him, I felt like that one inner area looked a little bit just off, a little hypopigmented, a little kind of gray tan. And sure enough, that was all melanoma under the microscope. Woods lamp is clutch. My 8-year-old daughter's favorite word at the moment is clutch. And I don't think that there's really a better way to describe how important this is to our clinical practice. I woods light everything. Any pigmented, honestly non-pigmented lesion that gets referred to me, I'm pretty much woods lamping everything these days. I think it's just an invaluable technique for really pre-op markings when you're treating these spots. And I would encourage, you know, anybody, even before you're doing a biopsy, if you're thinking about doing that broad-shaped biopsy, if you have one on hand, it's a great thing to get or to have on hand, because I think it can really help you kind of get a better pre-operative or pre-biopsy assessment of what you think you're looking at. So, you know, I don't want the focus of this talk to be about the actual what we do in the lab. I had this talk more geared towards previously giving it to some Mohs surgeons that were going to try to start doing melanoma with MART1 in their lab. But just to show a couple kind of key things for any Mohs surgeons that are, you know, listening in on us right now and thinking maybe it's something they'd like to try. It's not tremendously different how I approach these compared to our regular Mohs. There were lots of suggestions I got when I was talking to different people about how to do this. A couple things I used to have my staff aim with cutting these at 1 to 2 microns. We've evolved and we really do this now at pretty standard 3 to 4 microns, and we get very good staining with that thickness. Just some kind of minor little details. Black and blue ink show up better with our MART1, so we tend to use more of those ink colors on these days. And kind of contrary to how we normally do Mohs, where we really want that uniform specimen because we're really checking it kind of like a pie crust and we're getting that entire depth and periphery. Here, we're debulking the specimen at the time of removing the tumor, and then it's really all about that peripheral margin. So when I take the specimen into the lab, you can see on that gauze pad, kind of in that one photo, I'm really removing a lot of the fat from these specimens. It makes it easier for my techs to process the tissue. So that's just a little nuance. I used to do this. I ordered, when I started doing this, some non-gauze milk filters. That was one of the tips I had from Vermont. I don't really use them that much anymore, but you kind of want to lay the tissue down and very carefully kind of trim some of that fat, and that generally makes it easier for the tech. So. Again, much of this is just very, again, routine, how we would do just about anything. My map there shows you how I tend to section these into more pieces than I would for my normal Mohs. I find them easier to interpret. When I'm looking at the slides, I think it's easier for my text to process as well. So I'm almost routinely doing a 4 specimen plus potentially that strip of tissue that I was talking about, and then of course sending my debulk for consultation. The slide to the picture to the right, something I wanted to mention is that I think it's really key if you're going to start doing these and something that we try to make as routine as possible is that I always request the original pathology slides. I think this is really, really important to be able to see the tumor and get a sense of what that original biopsy showed, and to know what you're potentially looking at and what you're dealing with. So not to go through too much histology, but what are we looking for when we're looking at these slides, which certainly can be challenging. One of the features, we look for nesting, we look for 3 or more grouped atypical melanocytes. For superficial spreading type melanomas, we're looking for what I was kind of taught in residency is a buckshot scatter of those melanocytes into the epidermis, kind of the lower 2/3, I believe they typically go. Pagetoid scatter. So that upward migration of melanocytes. Confluence, I remember Dirk Elston saying, 8 or 9 is where you really, when they start to kind of party and get together, there's oftentimes 3 or 4. As soon as you get into 4, 5, 6, then you really need to pay closer attention. And certainly, 9 would be a little bit high. There's definitely some gray zone with this. And, you see people where, their baseline tends to be more confluent. So that can get a little bit tricky. Vertical stacking of melanocytes is something that we look for in melanoma. Certainly adnexal extension, so extending down the follicular epithelium. Lentigo malignas and these tumors are commonly asymmetrical. So that's meaning like the bilateral right to left asymmetry of the tumor. So if you're kind of scanning the slide, sorry, I thought that was one of my kids. If you're scanning the slides, oftentimes they just don't look even when you're going left to right. And then dermal nests of atypical melanocytes. This can be tricky when you're first starting out. I feel like this is something I've definitely tackled through the years. A lot of times you'll see dermal nests and it's just you've kind of run into a benign mole, benign nevus there. But certainly if you're starting, you want to distinguish between those. Histology pearls, and again, a lot of this just comes from Geisinger training for me, but even if it's appearing pretty bland, a broad junctional lesion on sun-damaged skin, it's kind of melanoma until proven otherwise. And I think that that's kind of one of those steadfast rules that I try to keep in my head. The dermal components of these melanomas, they're not maturing or dispersing in melanoma. Small well-nested lesions can be benign. That's certainly not always the case. We certainly see smaller melanomas, but again, those broader junctional kind of never seeming to end skip areas, those are more concerning. One of the things I just always have taken with me, both clinically and then histologically, is that horn cysts can occur in the epidermis overlying a melanocytic lesion. So, oftentimes we'll be kind of surveying somebody's skin and we'll see horn cysts in a brown lesion and think, oh, it's probably okay. But they're really not diagnostic clinically on dermoscopy for an SK. Certainly oftentimes it's an SK, but you don't want to kind of ignore a spot if it really is looking funny to you because you're seeing those. So just to kind of show you what we're looking at when we're looking at these tumors. So just a picture, again, my left is kind of normal, just kind of possible increased density of melanocytes there. And then you can see that, increased the confluence and what is pretty much clear cut melanoma in situ on the other side. Just normal patterns. You can get, certainly a lot of crowding and sun damage. You can get a good amount of, increased melanocyte density. Certainly some early confluence. In the upper right-hand side, you have tangential sectioning, which you don't want to mistake for pagetoid scatter or anything like that. You can get in the bottom picture kind of normal just follicular extension down that follicle, but then in contrast you have the clear melanoma in situ that's just extending down the follicle, just very confluent and clearly abnormal there. You can also get non-specific MART staining. So this can add to sometimes the trickiness of what we're reading. You can get inflammatory staining, as you see in 2 of these photos. You can get a follicular pattern. You can also get a dendritic pattern. So this is, some of that knowledge that you have to have when you're going about reading some of these, some of your stains. Reading slides. So, there's several ways to go about doing these. You can see in both of these pictures here, just very, very kind of ill-defined, broad, multicolored, atypical lesions. There are lots of things you can do to make your job easier. And certainly when you're starting off with these, you can have an H&E slide prepared in addition to each MART slide. That's not something I generally do just because of the, doing this in a private practice and being in a small lab. We stuck with just doing the hand dipping of the slides. We actually chose not to go with an automatic stainer, and it's worked very well for us. But, it certainly is a time-consuming process. And so for the most part, I will most often have just MART slides prepared. There are exceptions to that. I had a patient recently where it was melanoma turned squamous cell as well as melanoma. So, sometimes you will have variable slides prepared by your tech. You can have a positive control from the tumor, which is that kind of diagram I showed you all with this strip of tissue. That can be invaluable to be able to see the tumor in addition to requesting the original biopsy slides. I don't usually do a negative control from kind of like a distant sun exposed area. I think I've always been fearful that I'm just gonna, in somebody very sun damaged and covered in things, find something else that day. But it could be useful, if you have an area that's really looking pretty bland, just to get a sense of kind of what their background is, to compare that to what their tumor is. So, and that's about all I have.
Okay, we have Dr. Torihara has been patiently waiting to ask some questions. So you are unmuted, Dr. Torihara.
Thank you so much. Thank you so much for your great talk. It was really informative and very interesting. And I just had a few questions. So I know so basically you're just using MART1, you're not using any other immunostains. And so I think one of the things that I worry about, and I think that, it might be something that you've encountered as you look at MART1 stained slides, is that you see significant dendritic processes because it's not staining just the individual cells. You're seeing a lot of dendritic processes. And so, and actually some of those pictures that you showed where you're showing this confluent melanocytic proliferation, without having an H&E slide, do you feel comfortable knowing that those aren't just dendritic processes? Have you ever thought about using SOX10? And then the other concern is that without doing an H&E, is that you can't capture all of the dermal components. So, for instance, if you have a desmoplastic component, which doesn't stain for MART1, what's the literature on that? And I was just wondering if you could address some of those things.
Do you want me to take that, Julia? Yeah.
Well, so I think first off, for desmoplastic, we don't do most for melanoma for that exact reason. And in terms of, SOX10, that's not something I've thought of doing. Alyssa, what are your thoughts?
I think it raises really good points. I mean, certainly we, again, I think, one of the things when I was at Geisinger was it was just kind of this whole team. So you could have this whole panel of slides. You could have your H&E. They were doing MART1s. They were doing MITFs, and they were, having such a big group sitting down. So doing this on my own was definitely a little bit more intimidating. I have not, when I was sitting down and developing this protocol and sitting down with some of the dermatopathologists that I used to work closely with, I wasn't finding with our protocol and our staining that we were getting so much dendritic staining. So I wasn't really feeling like it was, I felt like I was getting really clear epidermal staining. I was always sending that debulk, which is debulked with about a 3 to 4 millimeter margin. So I was always sending that off to get a better sense of anything possible that could be lying, underneath or in that area. And I felt like I was just getting really good MART staining. I do feel like my next kind of venture with this is to try the MITF. I think that would be just an extra level piece of information. Obviously, with that being a nuclear stain and us just doing cytoplasmic stains right now, or a stain right now, which can certainly get a little muddy at times. So I think
in my experience,
yeah.
In my experience, the SOX 10 is a much crisper nuclear
SOX
stain,
10.
if that's what you're looking for.
Yeah.
MITF we've definitely been phasing out, but
Okay.
my concern about the dendritic processes is that if I were to look at so we do a lot of slow-mos in our practice because under fixed section, we can see really great crisp histology on H&E. And so you'll see under H&E that it really is very bland. There's nothing there. And then that in really sun-damaged skin around the lentigo maligna, you have really extensive dendritic processes, which can really kind of upstage the MART1 staining. So I guess my concern is if you're doing just the MART1 without having an H&E to compare it to, and without the fixed sectioning, do you ever find that you're encountering situations in which you're taking more margins or worry that you're, maybe not seeing just like the individual cells?
Right. Yeah, I mean, I guess, I'd like to talk to you about it more because I think I'd like to explore a SOX 10 for sure. I think it probably would make sense, given what you're saying, to do more, at least a, couple of the H&E for comparison. Again, I haven't encountered, we do a positive, or our positive control is by definition our melanoma slides, and then we do a negative control where we're blocking the antibody. So we're looking at it in that way, making sure that our MART's working well. Occasionally I'll see a little bit of dendritic staining. I guess I really haven't, I guess in my training, I kind of would generally write it off as more dendritic staining, just non-specific. If I do see slightly that, not really thinking it's impacting when I pretty much feel like I'm able to see kind of clear melanoma in the epidermis. But I, probably should give it more thought. I think it's a really good point.
I think what's also important to know is a lot of the studies done on, now my dog freaks out, done on melanoma in situ are using MART1s. And so especially the on-FOSS Zitelli studies where they then compared with H&E, I think that's what's reassuring for us, is that they've had essentially those side-by-side studies to show that with good training, you're able to do it well.
Yeah, no, it's awesome. I admire you guys for doing it, because I think that I've definitely seen a lot of melanomas that have sections that lose staining from MART1 because they're so de-differentiated. So not having the good sort of frozen, or sorry, fixed sections of H&E is it's hard to see unfrozen. So it's great that you guys are doing it.
Any other questions? All right, well, great talk. Thank you. I appreciate that. Dr. Baltz, your dog sounds very large.
She's a basset hound, so she's only like large in her body.
Okay.
Short in the legs.
Dr. Findley, children are very observant, so you do have a happy, smiling face at work.